Hi everyone, our group will be presenting on our simulation for Singapore's COVID facilities onboarding process. Our team comprises of Tao Che, Kok Tong, Ignatius and myself Dodi. Here are the pointers which we will be covering in our presentation. Firstly, why would we want to simulate Singapore's COVID facilities onboarding process? Recently, Singapore has faced a sharp increase in COVID-19 infections. Moreover, the new variant of the COVID-19 Omicron has the potential to overwhelm the medical facilities. Next, I'll share about our objectives. We intend to analyze the time frame required by the virus to overwhelm our ICU facilities. Also, we want to investigate whether the current or forecasted infection rates will overwhelm the ICU facilities. Next, we want to explore if there is a delay within the onboarding process which may proliferate the infection rates. And lastly, we want to investigate whether faster response times actually curb the infection rates. But before we continue, let's watch the sneak peek of our simulation.
Let's dive into our methodology. Our group first conducted preliminary research on the medical processes as an individual is tested positive on the ART test. This facilitated our understanding of the different entities that were involved in the process. Next was the process of synthesizing the discrete events that we have identified. Finally, we need to decide what data we should input into the simulation, in which we conducted further research to collect the relevant data. Next, let's cover the key assumptions. First, that the arrival rates and the service times followed a Gaussian distribution. Since we are running a simulation with more than 1,000 entities, the law of large numbers and central limit theorem allows us to assume so. Next, we assume that there's a certainty in death upon the lack of ICU beds. Lastly, patients do not transfer between wards. This is because concrete data of patients transferring wards could not be found and were taken to be negligible.
Thank you, Ignatius. We will now be looking through the main events and complexities of our simulation model. Our simulation consists of 4 key events: call center server and queue, Ministry of Health official response time, modeling ambulance as a resource, and finally ICU normal bed utilization. The call center serves infected citizens by relaying their statuses to the ministry. The MOH will issue an official response to the infected patients. The infected will board the ambulance should they need to recover in a hospital. The severely infected will be routed to the ICU. Our simulation also features 2 branching scenarios: home quarantine all hospital wards and ICU wards all normal wards. The patients either recover at home or in hospitals. The severe cases will be routed to the ICU while the rest will stay in normal wards. Our simulation also features 2 complexity enhancements: death upon lack of ICU beds and additional patients infected when more patients are quarantining at home. Upon the lack of ICU beds, every new entrant into the ICU immediately dies. Additional patients quarantining at home will increase the number of infected patients. Next, Kok Tong will be going through the analysis and insights from our simulation.
I will talk about our analysis. First, the time taken before healthcare system is overwhelmed. We assume that the daily infection cases is 4,000, the ICU bed capacity is 300, and the current ICU bed occupied is 150. We ask ourselves, what is the time taken for ICU bed occupied to go from 150 to 300? Based on our model, it took around 14 days. Second, the occupancy rate of ICU with varying daily infection cases. We vary the infection cases from 500 to 4,000. Then we ran the simulation and computed the occupancy rate of ICU beds. Based on our model, if daily infection cases exceed 3,500, the ICU will be overwhelmed. Third, the potential delay within medical onboarding process. Could there be any delay due to lack of ambulance? Based on our model, no delay was caused due to lack of ambulance. Also, no delay was caused due to lack of call service. Fourth, the benefits of faster response time. Our group realized that the limiting factor was not really the response time, but the ICU bed resource. Finally, we have 2 insights for our client. First, if the daily infection cases exceed 3,500, there's a serious risk of overwhelming the ICU bed capacity in just 14 days. Second, the capacity to increase the number of ICU beds is very important for protecting lives. Thank you.